let's get going with cardiovascular. And right now, you ought to be thinking like a test question writer. And if you are, you should know that in the realm of cardiovascular, there are 4 big areas where you're going to see questions. First, I know you'll see questions on hypertension. You got to know about that. And because I think you will take the exam in 2015, the way that you want to answer those questions regarding hypertension, I really think are based on JNC 8. All right, JNC 8. So we'll talk about that. I need to make sure that you know about heart failure. Obviously, it's very common in the United States. And while you may be sitting there thinking, I'm not taking care of those heart failure patients, I'm sending them straight to cardiology, you have a huge role in primary care with every patient who has heart failure. And I'll make sure you get those key points. We're going to talk about dyslipidemia, which means we need to talk about the new lipid guidelines, simplified really over what we used to do. And then finally, we need to talk about heart murmurs, because I think on your exam, you're going to see at least 3 or 4 questions on murmurs, or at least that's the feedback I get from students who've taken the exam. So let's get going, and we'll start with hypertension. You know, I guess unless you have been in a cave, JNC 8 came out more than a year ago. It came out sometime, actually right mid-December. And so it is certainly fair game on your exam, because as you know, it takes about a year or a year and a half for information to be out there before it finally makes it to an exam. So this is a way I think you should answer your questions on your exam in 2015. And so it gives us an opportunity to talk about why people have blood pressure that's too high. It turns out there are 3 reasons mainly why people's blood pressure is just too high. The most common reason is that these people have something called primary hypertension. You know what that means? Your blood pressure is too high and we really don't know why. Well, we got to treat you. The majority of hypertensives have primary hypertension. A very small group of people have something called secondary hypertension. It means their blood pressure is too high, all right, but it's because something else is going on. One of the most common something else's is something going on in the renal system. They have renal stenosis. They have something, renal artery stenosis. There's something going on. But honestly, it could be any of them. And sometimes it is a medication that drives blood pressure too high. Those people fall into a category called secondary hypertension. And here's why it's so important to find them. While it's not very common, you would never want to miss it. And the reason you never want to miss it is because if we can reverse the underlying reason, then we'll be able to get them off of medication, probably. So you never want to miss these secondary people. Consequently, I have a good question for you, and here it is. Which choices might be clues to secondary hypertension? And here we go with a select all that apply. All right, so look at number 1. Resistant hypertension despite the fact of 3 concurrent blood pressure meds. If you can't get their blood pressure where it needs to be, you need to think about something secondarily going on. Look at number 2, very important. Onset of hypertension before puberty. That should be a big red flag for you, right? Always consider secondary hypertension. Look at number 3. If someone begins to have a very elevated blood pressure, statistically after age 55, you need to consider secondary hypertension. And then finally, your last big one with regard to secondary hypertension is number 4. Someone who's non-obese, non-black, with negative family history and their blood pressure is too high, something is wrong. Something is up, and your job is to figure out what's going on. So honestly, what this question tells you are the 4 groups of people that you need to have a heads up and look for, because they are most likely to have secondary hypertension. Well, we've talked about primary. We've talked about secondary hypertension. The type of hypertension that we see almost exclusively in our elderly patients is called ISH, isolated systolic hypertension. It's exactly what the name says it is. Only the systolic blood pressure is elevated. The diastolic is normal. And in fact, sometimes the diastolic is even low. We used to look at that and say it was okay for your blood pressure to be 100 plus your age. How many people remember that? Raise your hand. Okay, we must have a very young crowd. All right, it used to be okay to be 100 plus your age. Now we know that's ISH, and the reason we jump on it is because it's a significant predictor, not just of strokes in elderly patients, but of MIs. So we don't watch ISH anymore, we jump on it. Listen, why do we see this almost exclusively in older patients? Like, why don't we see this in a 35-year-old? Why don't we see it in a 40-year-old? Here is probably the reason. As each of us ages, our vessels stiffen. And as they stiffen, it becomes more and more work for the left ventricle to push blood through those stiffened vessels. Consequently, the systolic blood pressure rises. That's why we think we see ISH in our elderly patients. All right? So the three types of hypertension: primary, secondary, and ISH. Now, we talked about the shift in the way we manage blood pressure that was a result of JNC8. I want you to remember that JNC8 is heavily evidence-based, which means we have good, well-documented research that demonstrates why these recommendations were made. To be honest with you, JNC8 to me is a cinch compared to JNC7. It tells you exactly what to do. So look, one way that you look at JNC8 is that it drives and predicts blood pressure and uses treatment for blood pressure based on age. JNC8 is age-driven. This is what I mean. For people who are less than 60 years of age, whether they have diabetes or kidney disease, JNC8 says their blood pressure ought to be less than 140/90. JNC8 is driven by age. If someone's age is 60 or older, JNC8 says we have good data. It's okay as long as their blood pressure is less than 150/90. They are not more susceptible to cardiovascular, cerebral vascular events if we let blood pressure get there. So what I would tell you is, when you think of JNC8, I want you to realize it is driven by the age of the patient. All right? So establishment, the first thing you establish is what blood pressure goal they ought to have. Then we arrive at the point where what drug should we give them? You remember what JNC7 said? Give everybody a diuretic unless you got a darn good reason not to. JNC8 said, hey, wait a minute. Not everybody responds well to a thiazide. In fact, we know that some people respond really well to other medications. You need to put these drugs in your brain. For patients who are African American, whether they have diabetes or not, JNC8 has data that says these patients do best if you give them a thiazide diuretic or a calcium channel blocker. And it turns out that our elderly patients do extraordinarily well with those two classes also. All right? For people who are non-black, which is JNC8's terminology, with or without diabetes, they do well no matter what you give them, with two exceptions. We don't use alpha blockers and we don't use beta blockers first line for management of hypertension in non-blacks with or without diabetes. So now you know the target or goal blood pressure, and now you know the best drugs to give. I would tell you that if you were keeping a suffix list, you might have several meds to put on your suffix list right now. Remember that the thiazide diuretics end in -ide or -ide. They're no longer first line, but they are excellent synergists. What's a synergist? It's a medication that you add to something else you got on board that makes both of them better than either one together. Look at the ACE inhibitors. Remember, those end in pril. Who does well with an ACE or an ARB? Young Caucasians typically. How come? Because young Caucasians, especially males, tend to be, you ready? High renin producers. These drugs work in the renin-angiotensin-aldosterone system, which means if you got a young Caucasian, my money is on an ACE or an ARB for a medication that will work very well with them. So pril and sartan ought to be two suffixes on your list. What about the beta blockers? We don't use them first line for uncomplicated hypertension. They make good add-on medications, but not first line or first choices. The beta blockers, remember, end in lol. The calcium channel blockers that you're going to use a lot of, the long-acting calcium channel blockers that end in pene, amlodipine, felodipine, those are the ones we want you to use. And then finally, as you realize already, most patients who have hypertension need more than one med. All right? Most people don't have one med that totally knocks out or gets their blood pressure to goal. With that, I think the best way to teach you these medications is to let you take care of some patients and manipulate some meds. So let's take care of some patients. And here's your first guy. It's Mr. Thibodeau. Mr. Thibodeau is having a good week because the Saints won this Sunday, right? So you see his Saints hat. I don't know what the Saints are going to do this weekend, but we'll see. Here is your guy. He's a 38-year-old male whose wife is a nurse. He brings in a log of his recent blood pressures. I'm sure his wife has taken him and documented them. What do you think? Yes. He states that he feels fine, but Amelie, I am here at my wife's insistence, and she wants to make sure you get these blood pressures. All right, so he's your patient. The first question I have for you is, can you diagnose him with hypertension today? Yes. And the answer is absolutely yes. Whether we look at JNC7 or 8, we want at least 2 blood pressures taken at different times that indicate elevated blood pressures, especially if they're these numbers. You got it? So what I would tell you, yeah, we can diagnose him with hypertension today. Let me ask you, of the 3 types of blood pressure or hypertension that we talked about, what type do you think he's got? Primary, secondary, ISH? Primary. Got to be primary. I mean, that's my best guess with him. So with that, let's talk about what to do next. Both JNC7 and 8 want you to consider getting labs in patients that you've just diagnosed with hypertension. They don't tell you exactly what to get, but they make some suggestions, and they probably are pretty good. The labs that you get are not nearly as important as why you get them. Why you get the labs is the most important thing. Let me go through them with you. The first thing, or the biggest reason we get labs on patients when we diagnose them with hypertension, is to find out which one of these patients has target organ damage. What does that mean? It means their organs have taken a beating from their elevated blood pressure, and what it means for you as a prescriber is you got to get on it. You got to jump on their hypertension and see if you can stop or slow down target organ damage. That's one reason you get labs. The second reason you get labs is to find out if this patient with hypertension sitting in front of you belongs to that small group of people who has secondary hypertension. Because how embarrassed would you be if you had a patient with hyperthyroidism and you were treating them for hypertension and you missed the hyperthyroidism? You would be embarrassed, and you should be. So you're always on the lookout for those people that might have secondary hypertension. To me, the most important reason you get any lab on a patient you've just diagnosed with hypertension is to find out what else they have. I would bet you that collectively in this room, we have taken care of at least 25,000 hypertensive patients. Between me and you, we've taken care of thousands of them. Of those thousands of hypertensive patients, how many of those people only had hypertension? They had nothing else. They didn't have hyperglycemia. They didn't have hyperlipidemia. They didn't have obesity. They had nothing else going on. How many? Not many. The take-home point is that when a patient has hypertension, they have something else. You got to find it. You got it? You have to be able to find it, and you got to be able to manage it. So that's why JNC7 and JNC8 want to make sure that when you diagnose a patient with hypertension, you get some labs on them. Is everybody with me? You good? All right, let's keep going. I've talked about target organ damage. Help me with this question. What are some examples of target organ damage secondary to hypertension? And I want to know, select all that apply. Well, I would tell you proteinuria, right? Very common. That's one of the reasons you get a urinalysis. Flame hemorrhages and AV nicking, where do you find that? In the fundus of the eye, which is when a patient comes in with hypertension, you're supposed to do a fundoscopic exam. You remember our conversation from yesterday? Okay, good. And what about left ventricular hypertrophy? Absolutely. So all of these represent examples of secondary hypertension and target organ damage. So listen, I think your exam is all about eye things, ophthalmology things. And so I think it would behoove you to learn some of these terms and phrases. I don't think you need to be able to recognize it on the exam, but certainly if you see flame hemorrhages, If you see cotton wool spots, you better think this is a diseased eye. This patient's got hypertension, they have diabetes, they have both, something is going on. These represent disease states in an otherwise normal eye. So back to Mr. Thibodeau. You got labs on him. They were unremarkable. There's no suggestion of secondary hypertension with him. And he tells you, I'm a chef, but I'm thinking about losing weight. Here are his blood pressures. There's not a single one up here that makes me jump for joy. I guess I'm okay with the one at 138/85, but really the others need some help. What are we going to do with this man? Do you want to start him on a drug today? Probably not. Both JNC7 and 8 say, listen, why don't you go with some lifestyle modifications? And this is what they ask you to do. Now, these are things that everybody in this room knows all about. These are the lifestyle modifications that we want our patients to engage in. But here's how I want you to look at them. I want you to look at these, and I want you to look at the numbers in parentheses after the intervention. You see the numbers? You know what they represent? They represent how many points systolically you can drop blood pressure if your patient engages in that intervention. So take a look. Suppose you got a very motivated patient who said, Amelie, look, I know my blood pressure is too high, but I don't want to be taking a medicine every day. What do I need to do so I don't have to take a blood pressure medicine? If they were motivated and engaged in each of these interventions and they got the minimal drop in blood pressure, you could drop blood pressure, look, 8 points plus 5 is 13, 17, 19, 21 points systolically. Do you realize how many people that will get to goal? Loads of them. What's the problem with these interventions? People don't do it. They don't do it. So here's what I do. I have these laminated in each of my exam rooms. When a patient comes in with hypertension, I hand it to them and I say, this is what I would love for you to be able to do. You think you can do them? My patients are pretty honest. They look at it and they say, Amelie, you must be kidding. I can't do all this. I'll look at them and I say, I totally understand. I mean, it's really hard to do all of this. Let me ask you this. You think you could just pick one? When you ask them to pick one, they look at your list very differently. And they usually say something like, well, you know, I've been thinking about losing weight. Let me work on that one. Great, Miss Boudreaux, that's a great idea. When they come back 2 or 3 or 4 months later, you know what? I give them the list again. Pick another one, Miss Boudreaux. At the end of a year, Miss Boudreaux is likely to have 2 or 3 new good habits. Or at the very least, she knows what she ought to be doing. And you know, you can't want more for your patients than they want for themselves. You got it. You do the best you can, but like this is a two-way street. So anyway, I think that helps. I would encourage you to use it or at least consider it. So go with some lifestyle modifications. Look at your next question. If a medication was chosen to treat Mr. Thibodeau's hypertension, I want to know what would be your first choice, and I want to know why. So look at his blood pressures that he's brought you. Seems like they're going up. What do you think? Yeah, so what drug do you want to give him? He looks to be about 40-ish. Would you call him a young Caucasian male? Yes. What drug class works well in him? An ACE or an ARB, because he's a high renin producer, and the ACEs and ARBs work well in the renin-angiotensin-aldosterone system. I'm all about circling number 2, lisinopril. Well, after 4 weeks on his lisinopril, Mr. Thibodeau's blood pressure is in the mid-120s over the mid-70s. Are you happy? I'm a happy girl. That's a great blood pressure. But you knew this was coming. He complains of a dry cough. Well, you know what it is, right? What's the cause of his dry cough? It's an ACE inhibitor, but that's not a choice. What about the ACE makes people cough? It's bradykinin buildup, right, in the lung that produces that cough. And it doesn't happen in everybody, but when it happens in one of your patients, I'll tell you right now, they cough. So how might this be handled? We could get him off the ACE and do what? Consider an ARB, right? So still working in the renin-angiotensin-aldosterone system. Good job on Mr. Boudreaux. Here's your next patient. Or no, that was Mr. Thibodeau, sorry. Sometimes you do that with the real patients too. You call them by the wrong name. You never did that before? Okay, you hadn't taken care of enough patients. All right, so here's your next patient, Miss Boudreau. Look at Miss Boudreau. She's very pensive, if you ask me. She's thinking about something. Here's her deal. She's 80 years old. She's completely independent. She cares for her elderly husband. She exercises, the fountain of youth, 15, 20 minutes daily. And look at her blood pressure. Her average blood pressure is 160/70. And look at her BMI, 23. Here's her history. She's got coronary artery disease with a stent that was placed 5 years ago. She's got hypertension, osteopenia, hyperlipidemia, and osteoarthritis. I'm looking at her and I'm thinking, she's a darn healthy elderly adult. Look at the meds that she takes. She's on Fosamax for obvious reasons. She's on Pravastatin for obvious reasons. She takes 10 milligrams of Fosinapril with 12.5 of ACTZ every morning for her blood pressure. And she uses naproxen PRN. Now, you know that as NSAIDs go, naproxen is probably safest for her with her cardiac history. You got it? So she's your lady, she's your patient. Let's see what they want to know. On your exam and in an exam room, you'll be asked to look at something else. These are her fasting labs for today. Take a look. BUN and creatinine, here are her results, and these are the normals. BUN creatinine looks good. Potassium looks good. Why are you worried about that? Because she's on an ACE inhibitor with an HCTZ. Want to make sure potassium is good. Look at her lipids. I'm thinking she probably is taking her Pravastatin every day because her lipids, wish mine looked that good, right? What else? What about her fasting glucose of 88? You happy with it? Absolutely. Vitamin D, good. Want to make sure that's up because of why? Osteopenia, she's on Fosamax as well. And TSH is good. You know what I would say? Miss Boudreau looks like her labs, just as we talked about yesterday. So yeah, these are beautiful labs. First question for you. With a blood pressure of 160/70, what kind of hypertension do you suspect she's got? ISH, isolated systolic hypertension. And if that's the class that she's got, or type of blood pressure, then I would ask you, what's the drug class of choice? It's a long-acting calcium channel blocker that ends in peen. Let's talk about why that's that. You remember from pharmacology that the calcium channel blockers are divided into two different categories. We have the DHPs, dihydropyridines, and the non-DHPs. When we treat hypertension, our preferred calcium channel blocker is always a DHP, and here's why. The DHPs decrease blood pressure, but not heart rate. The non-DHPs, like diltiazem and verapamil, drop heart rate and blood pressure a little bit. So listen, the way I remember that is I remember that the DHPs are the ones I want to use for blood pressure, and I remember that DHP means doesn't hurt the pulse. It doesn't drop the heart rate. It drops the blood pressure, and that's what I want. So I'll use a DHP, and you will too, and I'll remember that these end in peen, like amlodipine, all right? And I think you'll see that drug again on your exam when they ask you about calcium channel blockers. Everybody got it. You with me? So that's a drug we'll give Miss Boudreau. Here's another question for you. Miss Boudreau was 80, right? The question is, how much amlodipine would be appropriate for initial treatment of Miss Boudreau's blood pressure? And they'll give you the normal dosage of a medication if they ask you to choose how much to give. You don't need to remember dosages. So look, usual is 5 to 10 per day. How much you want to give Miss Boudreau? Is anybody thinking maybe 5 or maybe 2.5? I'm thinking 2.5. I'm thinking 2.5. I can always give her more. But if she is one of those people who really responds to 5 milligrams of amlodipine, and she has a hypotensive episode, she's never going to want to take my medicine again. All right, so I'm going to go with 2.5. But to be honest with you, 2.5 once a day is probably a clinical judgment. Don't think they're ever going to ask you on an exam, is it 2.5 or 5? But 2.5 certainly is reasonable. All right, everybody with me? All right, let's keep going. So Ms. Boudreau returns to the clinic in 2 weeks. Her blood pressure that was 160 over something is now down to 145 over 85. Like, I'm happy. She has 2 complaints. What are her most likely complaints? If she's taking amlodipine, there are two things you watch out for, especially in older patients. One is constipation, the big C. And what is common in anybody who takes a calcium channel blocker? It is a common side effect to exhibit lower extremity edema, right? So it isn't just specific to elderly or young patients. So I think number 3 is what she's going to complain about. Listen, is she at goal with that 2.5 of amlodipine or 5? She's at goal. What was her goal according to JNC-8? Less than 150/90, and she's there. So let's leave her where she is. Let's take care of another patient. You ready? Here's your guy, Mr. Jones. Mr. Jones is a new patient to your practice. He's a 66-year-old African-American who is a retired postal worker. Okay, no, that wasn't a joke. All right, so here's his deal. He's hypertensive. He's got, look, borderline diabetes. Is that like borderline pregnancy? It is. So, all right. So he tells you I'm a borderline diabetic. He's got hyperlipidemia. He's got gout. He's got BPH. And he's got osteoarthritis in his knees. You know what I'm going to ask him? Hey, Mr. Jones, tell me about your job at the post office. Were you a walking postman? What do you think he's going to tell you? I bet he was. If he's got osteoarthritis in both knees, I want to know. And you know why you ask your patient those questions? Because when you get to know them better, you're a safer provider and you're a safer prescriber. But you know what the patient knows about you? You really care about the patient. That's something that nurse practitioners do a very good job of. So anyway, that's his history. Look at the drugs he's taking. He's on 50 of losartan and 12.5 of HCTZ. Somebody's given him 10 of atorvastatin. He takes Flomax daily. He's on 81 milligrams of aspirin, and he takes naproxen PRN for knee pain. All right, so he's your guy. Look at his blood pressure, 170/90. Heart rate looks good. What do you think about his BMI? It's elevated. Look at his fasting labs from today. Remember, he's a new patient to your practice. His A1C is 7.9. What do you know about that? It's elevated. Listen, anytime you see an elevated A1C, I want you to go and look at the patient's glucose because I want you to make sure that there's congruence between those two numbers. If his glucose was normal, I would seriously doubt that A1C. His glucose is not normal. A fasting in him is 165. What are you thinking about this man? He's not borderline, right? Mr. Jones, you have diabetes. We're looking at next his BUN and creatinine and an estimated GFR. You remember what we talked about with an estimated GFR yesterday? What number are you always looking for? 60. It means you can give them a drug and have a reliable, or be assured that they're going to get rid of the drug. BUN and creatinine is a little elevated. What you think about that? Are you worried about the naproxen that he is taking?
Yes.
It's an NSAID. You know what? I got to find another way to help his knee pain. I want him off that naproxen until we can see what's what with his kidneys. Look at the potassium. It's holding, right? He's on losartan. What do the ACEs and ARBs cause you to do with potassium? Hold on to potassium. So despite his kidney disease, his potassium is okay. I want you to look at his lipids. 210, not horrible, but I wish it was better. LDL's 130, not horrible, but I wish it was better. HDL's at 28. When you see low HDLs, I want you to go and look at something else in the patient's lipid panel. And here's what I want you to realize. I am convinced that life is about recognizing patterns. Once you recognize a pattern, no matter how it's disguised, you know what it is. There's a pattern that I always want you to look for when you look at patient lipids. Anytime you see a low HDL with elevated triglycerides, I want you to look at that patient and say or think you have insulin insensitivity. And you know what? That matches his A1C and fasting glucose. They're both elevated. So low HDLs and elevated triglycerides, think insulin insensitivity. The other thing I'm looking at is a PSA of 1.6. Great. So this is your guy. You ready to take care of him? Oh, that's not real confident. You ready to take care of this man? Of course you are. Let's see what they want to know. The first question is, what is your goal blood pressure for Mr. Jones? According to JNC 8. Well, you know what? We have a little dilemma here. Because how old is this man?
66.
66. If he's 60 and older, less than 150 over 90, he's got kidney disease and he's a diabetic. So I don't know. I think I may want to get him at 140 over 90, although that might not be an evidence-based plan. All right, but we've got to get his blood pressure lower than it is right now. So he's age 60 or greater than 60. He's diabetic and CKD. I would invite you to use your good judgment about what your goal blood pressure for him ought to be. Remember, it's 170 over 90. We used to call that stage 2, but JNC 8 says, listen, if the systolic is 20 points above your goal, or the diastolic is 10 points above your goal, you need to start him on a drug today. In fact, you ought to consider 2 drugs today. So let me ask you this. What is your plan for management of this man's blood pressure? Well, you have several options. Remember that he is on 50 of losartan and 12.5 of HCTZ. We could possibly increase his losartan to 100, so I want you to circle that one. That's a possibility. I'm not interested in increasing his HCTZ to 25, and I got 2 good reasons. One is this man has a history of gout. I'm not even sure I want him on HCTZ to begin with, but if I increase him to 25, I think I'm going to precipitate an episode of gout. I'm not interested in doing that, but I got a better reason for not increasing his HCTZ. This man's a kidney patient. We need to load him up on water, not get rid of it. So if you want to make these kidneys work better, we've got to pour more fluids in him. So from my perspective, increasing his HCTZ to 25 is off my list of options. Look at choice number 3. Add amlodipine 5 milligrams. I love that thought. It represents using a drug from a different class. This man is older and African American, and what drugs do they eat up? Calcium channel blockers. So I'm liking number 3. And number 4, why wouldn't we choose 10 of amlodipine? Start him at the lowest dose and see how he does. So that's my choices. I'm going to circle number 3, and I'm going to circle number 1. Now, suppose you increase his losartan to 100 milligrams daily. What must you monitor? And I want to know what you're worried about, because I need to make sure you're worried about what I'm worried about. Losartan, where does that drug work? Renin-angiotensin-aldosterone system. He's got kidney disease. You worried about maybe pushing him over the edge? Maybe. What must you watch if you give him losartan? Look at number 2. You got to watch a BUN and creatinine. You must watch his potassium, and you got to watch his blood pressure. So select all that apply. I'm worried about number 2, number 3, and number 4. Does losartan change his heart rate at all? Not a bit. Everybody with me? All right. Suppose you decide to add amlodipine, and I was all over that one. What must be monitored if you give him amlodipine? Do you have to monitor his heart rate? No, because amlodipine doesn't drop heart rate. What does it drop? Blood pressure, right? It's a DHP. Do you have to monitor his BUN and creatinine if you add amlodipine? No. Do you need to worry about a drug interaction with atorvastatin? Oh, wait, do we need to with a calcium channel blocker and a statin? Well, in fact, we don't on this one because it doesn't represent a drug interaction. But remember with your calcium channel blockers, watch out for drug interactions. Look at number 4. What do we need to monitor if we put him on amlodipine? The only thing I'm worried about is his blood pressure. You got it? So circle number 4. So let me ask you, given losartan and amlodipine, what would be your choice to put him on? Amlodipine sounds like a better idea. So back to his fasting labs. So let's add amlodipine and we'll be done with his blood pressure, at least for now. Let's go back to his labs, and we got something else we got to fix. What about his lipids? We told you about the pattern, the 28 HDLs and elevated triglycerides, but this man's a diabetic. With the new lipid guidelines, what do they say? The new lipid guidelines say, listen, there are 2 reasons your blood pressure is elevated. If you listen to the Vytorin commercial, I think they pulled it off the air, but Vytorin commercial used to be good. You know what it said? There are 2 reasons why people's blood lipids are too high. They showed a hot apple pie, and it was like steam coming. I could almost smell the hot apple pie. What you eat drives your lipids up. What's the other thing that drives your lipids up? Your genes, and they would say Aunt Sally and Uncle Harry. So listen, what you eat will impact your patient's lipids. So we need to talk to him about lifestyle modifications. If he's eating, you ready for this? Lord sandwiches, we need to let him know that's not a good idea. I had a patient just a few weeks ago who told me I could not get his lipids down no matter what I gave him. And I began to really ask him about what he eats. You know what he eats every day for lunch? A lard sandwich with bacon drippings. Like, oh. The minute we pulled him off his lard sandwiches, I am certain that his repeat lipids will be better. I am certain of it. So find out what they eat, and that will really help you. But again, you know these lifestyle modifications. We used to say lifestyle modifications for 3 months, up to 3 months, and then if they're not where they need to be, put him on a drug. But the new lipid guidelines say, because this man's a diabetic, what do they say? Put him on a statin today. Use your lifestyle modifications, but put him on a statin today. Why do we use statins, and why are the new lipid guidelines all about putting the patient on a statin? Because statins are the only drug class that are known to reduce morbidity and mortality associated with coronary artery events. It is the only one for both primary and secondary prevention. It is all about statins. So I'd invite you to remember that. I also want you to know how we arrived at that. Remember the new dyslipidemia guidelines are a joint guideline from American Heart Association and the American College of Cardiology. They divided patients into 4 groups. 4 groups of people who would profit from statins. The first 2 groups are people that we've known about for 3 years. We've had loads of data that say that if you belong to group 1 or group 2, you profit from being on our most potent statin. The new lipid guidelines added groups 3 and 4. Our patient, Mr. Jones, belongs to group 3. He's diabetic between the ages of 40 and 75. And his LDLs are between 70 and 189. The new guidelines say we have evidence that shows that if you put him on a statin that reduces his LDLs by 30 to 49%, you will reduce his risk of an event down the road. It is considered a moderate potency statin. That's what a 30 to 49% lipid lower or LDL lowering capacity of a statin is. So listen, how are you going to remember all that? Well, it's easy. It's very easy. When you need to have the most punch with a statin, there are only 2 that give it to you. Atorvastatin and rosuvastatin in high doses. So when you got to hit a 50% or more LDL lowering capacity, those are the only 2 drugs that do it. The other drugs are the ones that typically are considered at moderate LDL lowering capacity, and that's what all the other statins are. So when I had a question for you just a little while ago and asked you if we had to worry about a drug-drug interaction with amlodipine and atorvastatin, you remember I told you don't have to worry about it, and you don't. You would have to worry about a drug-drug interaction with amlodipine and simvastatin. So what's your take-home point? The take-home point is when you start mixing statins, especially with calcium channel blockers or other drugs, make darn sure you do a drug-drug interaction. You got to check for drug interactions. And if you don't trust yourself or you want another eye to look at it, on your prescription, make sure you document what other meds the patient takes so that when the pharmacist gets your prescription for a new medication in their regimen, the pharmacist will do a drug interaction check as well. They routinely do that. The pharmacist would pick up simvastatin and amlodipine as a drug interaction. You got it? So just watch. The statins can be very dirty, meaning they interact with a lot of other drugs, or they can be clean as a whistle, like 2 of my favorites. Pravastatin, I could get on a street corner and sell. It's clean as a whistle. So is rosuvastatin, which is Crestor. clean as a whistle. So watch drug-drug interactions with the statins. Everybody got it? You good? Let's talk about heart failure. And we used to think of heart failure as a disease, and it's not. Heart failure is a syndrome. What's a syndrome? It's a collection of symptoms. So look at the symptoms we see when a patient has heart failure. We see dyspnea on exertion. We see fatigue. And I'll tell you, as someone who's taken care of loads of cardiac patients, when a patient who's got cardiovascular problems tells you, I am tired, red flags ought to go up. When it's a coronary artery disease patient, you better get those arteries checked because they're blocking up. When it's a heart failure patient who tells you, I am tired, they're going into failure. So it's a huge complaint to listen to from a cardiac patient. That's one of the other symptoms they got. And then finally, the one you know they have is fluid retention. Those three symptoms constitute the symptoms that are associated with the syndrome called heart failure. Now, I want you to think of heart failure maybe a little differently than you have before. You might say, Amelie, I'm not taking care of those heart failure patients. They're going to cardiology. Somebody else is taking care of them. That's okay. But in primary care, you have a huge role. A huge role with these heart failure patients. The first thing you must be able to do is recognize when they go into failure. And the earlier, the better. So let me show you how it goes. When you go into heart failure, you begin to hold on to fluid. The first place that you put fluid when you begin to hold on to it is in this tank right here, which means that the earliest signs and symptoms of heart failure are changes in heart rate, heart sounds, and breath sounds. Those are your earliest symptoms. When this tank fills, you begin to fill your peripheral tanks. You begin to fill lower extremities. So when you see fluid in lower extremities, that is never an early sign of heart failure. It's always a late sign, and it means the primary tank is already full of fluid. You follow me? So what do you need to be able to do on your exam and in a clinic? You have to be able to pick up the signs and symptoms of early heart failure. The minute the heart begins to go into failure, you know how it tries to compensate? It increases its rate. So tachycardia is a very sensitive sign of heart failure, as is tachypnea. When you listen to patients, do you hear crackles? You ought to be thinking about fluid that's on board. Think about hearing an S3 and or an S4. All of those ought to make you think about a patient who's got heart failure. That's one of your huge jobs in primary care. But you know what else? You got more to do. Let me show you what you need to make sure you're taking care of. You need to make sure that in every heart failure patient that you've got those primary care diseases well managed. You never want to take care of a patient with heart failure who's got thyroid problems. I can promise you their heart failure will be worse. And I'll also tell you that cardiology has no interest in chasing your patient's TSHs. That's your job. If you have a diabetic with heart failure, you need to make sure you're all over the A1C and that you don't give them a drug that worsens their heart failure just to treat the glucose. And I'll show you those drugs in a minute. You need to make sure, look at your second bullet. You need to make sure that you say exactly what cardiology says. When cardiology says, Mr. Boudreau, you're doing great, but don't stop taking your medicines. That's why you're doing great, Mr. Boudreau. You need to say that too. Here it is Thanksgiving or Christmas or a holiday. You need to say, Mr. Boudreau, listen, you really need to watch your sodium. You know, we have more heart failure patients in the ER on Thanksgiving than any other day of the year. Mr. Boudreau, do you know that? What's he going to say? Okay, I'm going in Friday. Listen. So my point is, you got to talk to him and tell him about sodium and taking their meds. And then finally, your big job, don't put them on a drug that contributes to heart failure. And this, if you don't remember anything else I've told you, I want you to remember this about heart failure. Take a look. What medications should be avoided in a patient who has heart failure? Would you worry about putting them on atorvastatin? Not really. Would you worry about putting them on aspirin? Not really. Would you worry about putting them on amlodipine? Really? Yes. What's amlodipine? What class does it belong to? It's a calcium channel blocker. You know what makes muscles contract? Calcium. So if a patient's got heart failure, the drug class you never want to put in them is a calcium channel blocker because it decreases the contractility of the heart. And that's the worst thing you could do for one of these patients. So I am doggone worried about amlodipine if he's got heart failure. Look at number 4, celecoxib. Am I worried about that one? Oh, I'm all over that one. Why am I all over it? Celecoxib belongs to what class of medications? It's an NSAID. What do NSAIDs cause you to do? Look, hold on to sodium. Everywhere sodium goes, what goes? Water. The more fluid that a heart failure patient has on board, the harder and more great the workload of the heart. So the 2 drugs you should be most worried about in a heart failure patient, never amlodipine or one of the calcium channel blockers, but always get them off those NSAIDs. Everybody with me? Okay. You get the idea that cardiac's a tough one? It's all those drugs, right? So it's tough to manage these meds. Let's talk about heart murmurs. Oh, Amelie, do we have to? Yeah, we do, because I know you're going to see this on your exam. So listen, I have a goal for you for 2015. I want your goal to be twofold. 1, to be successful on the exam. And the second part of your goal I want you to have is to learn your heart murmurs, because they're not nearly as difficult as people have led you to believe that they are. And the way that you can make heart murmurs easy is to change your perspective. When you hear a murmur, I want you to think a murmur is nothing but a noise I hear when there's turbulent blood flow. That's all it is. It's noise. It's a noise you hear. If blood can't whisk through the valves, vessels, and chambers without some interruption, you hear noise. And that's what a murmur is. That's all it is. So I want you to consider and begin to think of heart murmurs like that. Now, humans have how many heart valves? 4. In adults with murmurs, there are really only 2 valves that cause trouble. The aortic valve and the mitral valve. So children are the ones who typically have pulmonic and or tricuspid problems. In adults, we don't usually worry about those. So I've cut your work down from 4 valve troubles, 4 valves that give trouble, to only 2 valves. Do you feel good? You should feel very good, right? So you only half your work is done. Let's talk about aortic and mitral valve problems. Well, let me ask you this. What does a heart valve do all day long and all night long? It opens and closes. That's what it does all day and all night. Now, sometimes valves become diseased, and if they can't open properly, we typically describe that valve as a stenotic valve. How many people have had a chance to see a human or a dog or a cow valve open and close in a live whomever? How many people? Okay, not so many. So listen, for everybody else, this is exactly what it looks like. I want you to take your thumb, your second finger, your third finger, put them together just like this and make a little triangle. You see it? Now I want you to look at the triangle that you just made and realize that that is exactly what a tricuspid valve looks like. You see where your 2 fingers come together? That's the cusp. So this looks exactly like a tricuspid valve. Now, I want you to imagine that your valve just popped open. So pop your fingers apart and imagine that blood just shot out of it. Now bring your fingers back together and the valve closed. That's exactly what is supposed to happen. Suppose you have a stenotic valve, which means that your valve doesn't pop open so well. I want you to bring your 3 fingers together. I want you to move them apart only as far as they don't touch, and I want you to look at how narrow that opening is. Now I want you to imagine now it's got to happen. The chamber behind that valve is going to have to work really, really hard to push blood through that narrowed opening. You got it? What's going to happen to that chamber? It's a muscle. What's going to happen to it? The chamber is going to enlarge. And you know what happens when chambers enlarge? The electrical circuitry through them becomes interrupted. What is that patient going to be at increased risk of? Arrhythmias, like atrial fib, like PACs, like PVCs. So right now you ought to be thinking, when patients have diseased valves, it impacts the entire heart. And in fact, it's not just a mechanical problem, it can become an electrical problem as well in the heart. So listen, suppose the opposite problem happens. It's not a stenotic valve. Suppose it's a regurgitant valve. If you have a regurgitant valve, it means that your valve can't close properly. So I want you to take your 3 fingers. I want you to pop them open like blood just shot out of your heart. And I want you to bring your fingers really, 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 really close together, but don't let them touch. This is what your valve looks like when it's supposed to be closed. You know what's going to happen? Blood that just shot out of it is going to come back as a backflow into that chamber at the same time that blood is coming around this way to fill it. The chamber is going to be filling from two different directions. What's going to happen to the chamber? It is going to overfill. It's going to stretch. When the chamber stretches, how does that impact electrical activity in the heart? It changes it. What's the patient going to be at increased risk of? Arrhythmias. You got it? So that's what happens when you have valves that don't function properly. It impacts the entire heart. So is everybody with me? All right. Suppose you tell me, all right, Amelie, yeah. I got to deal with the three fingers and opening and closing. But what am I supposed to do on Monday morning when I hear a murmur and as I put a stethoscope on a patient's chest? Well, I'm going to make a bet with you. I can teach a fourth grader to diagnose murmurs. Are you as smart as a fourth grader? Are you? You are. You're way smarter, which means you can easily master your murmurs. Let me show you how you will master your murmurs. When you think you hear one, and most people tell me, I hear it. I hear the noise. Here's the first thing I want you to do. I'm going to call it Amelie's 3 easy steps to murmur identification. Easy. A fourth grader can do it. Here's the first one. The first thing I want you to do is figure out whether you hear the noise in systole or diastole. I want you to identify where in the cardiac cycle you hear this noise. So this is what my students tell me. Amelie, I hear the noise, but I can't tell if it's in systole or diastole because it's too fast. If that's your problem, I can fix it in a second. This is all you have to do. You take your stethoscope and you put it on the patient's chest and tell the patient, listen, I'm going to listen to your heart, so don't be alarmed. Listen to the place where you hear the noise the loudest, and I want you to listen for the noise. I want you to take your other hand and I want you to put it right over the patient's carotid. If the noise you hear is in conjunction with the patient's carotid pulse, it has got to be a systolic murmur. What's going on when you palpate a carotid pulse? Systole. So that the noise you hear is in conjunction with the carotid pulse, it's a systolic murmur. If the noise you hear is not in conjunction with the carotid pulse, what's it got to be? Diastolic. Easy. That is the very first thing you're going to do, and I think you got to be a fourth grader to do that one. That's the toughest thing I'll ask you to do. The second step to murmur identification, a second grader can do. You take your stethoscope and you march it around the patient's chest, right over those mitral aortic listening points. So listen, take your stethoscope, listen right here in the aortic listening point, and move it around. I want you to tell me where you hear the noise the loudest. And the reason I want you to identify whether you hear the noise loudest in the aortic or the mitral listening point or wherever it is because murmurs are loudest where they originate. So listen, my voice, think of my voice as a murmur. You can hear my voice better in this room than in the hall because my voice originates in this room. Murmurs are loudest where they originate. So I'm going to make a bet with you. If you put a stethoscope on a patient's chest and you hear the murmur loudest in the aortic listening point, put $100 on the table. Bet anybody in the room that is an aortic murmur. And you're going to take their money every day. If you hear the noise loudest in the mitral listening point, put $100 on the table and bet anybody in the room that's a mitral murmur. You will take their money every day. Because murmurs are loudest where they originate. You got it? A second grader can do that one, and you can too. The third thing a kindergartner can do. Hey, Mr. Boudreau, with the murmur I hear during systole over the aortic listening point. Hey, Mr. Boudreau, you got anything else going on? Like, are you short of breath? You have chest pain? You have exercise intolerance? Mr. Boudreau, you got anything else going on? And the reason you ask that question is because murmurs that are associated with bad company are bad murmurs. Chest pain with a murmur is bad company. Chest pain with shortness of breath is bad company. So when you hear a murmur with one of these things, I want you to remember murmurs are known by the company they keep. And when you hear that patient is not yours anymore, you send them right over to cardiology. You got it? What you think? It's easy. A fourth grader can identify murmurs. Let's look at these again. You ready? Amelie's 3 easy steps to murmur identification. First one is the noise you hear in systole or diastole. Check the carotid. The second thing, where do you hear the noise the loudest? The third part you ask, is anything else going on in conjunction with this murmur? Because if it's bad company, it's a bad murmur, and your work is done. You're sending that patient over to cardiology. Everybody got it? How do you know the name of the murmur? Oh, Amelie, we need to know that? Okay, so let me help you. I'll tell you that when I learned murmurs, the hardest thing for me to remember was whether it was systole or diastole. I could not remember. It was aortic regurg. I never could remember that. But I found something that helped me, and I think it'll help you too. Look who's come to help you learn your murmurs. My heartthrob, Peyton Manning. So listen, everybody knows who Peyton is, right? Peyton has been in the league now for, I guess, 16 years. Peyton played for 14 years where? Indianapolis. They decided 3 years ago that he was expendable. He went over and now he plays for the Denver Broncos. But you need to know about Peyton. Peyton is from New Orleans. Peyton is a graduate of the University of Tennessee. Peyton is a good guy on and off the field. I don't know if you know this about him, but he has donated tens of millions of dollars to build a children's hospital in Indianapolis. He gives loads of money to different organizations. He's a good guy on and off the field. Peyton is the only 5-time MVP in the NFL. He's going to win his 6th one this year. Anybody want to bet with me? Last week I was in Houston and somebody said, oh, Amelie, J.J. Watt is going to win it this year. Well, I saw he had his 5th interception yesterday or 2 days ago. I don't know. My money is on Peyton, and I think he's going to be the 6th MVP. Listen, who else is even close to 5 MVPs? Tom Brady's only won it twice. Brett Favre's only got it 3 times. My money is on Peyton. So when they announce it at the end of January, send me an email, all right? So listen, Peyton has come to help you learn your murmurs. You see, there he is again. All right. So here's what I want you to say with me. Mr. Peyton Manning is MVP. Mr. Peyton Manning is MVP. Mr. Peyton Manning is MVP is a mnemonic for every one of your systolic murmurs. Look, Mr. MR, mitral regurg, it is always systolic. Peyton Manning, PM, physiologic murmur, it is always systolic. As MVP, AS, aortic stenosis, always systolic. And he is the league's only 5-time, soon to be 6-time MVP. MVP is mitral valve prolapse. It is always systolic. Now, how did Mr. Peyton Manning get to be a 5-time MVP? With his arms, because he's a quarterback. Arms is a mnemonic for your 2 diastolic murmurs. The AR of arms is aortic regurg, always diastolic. The MS of arms, mitral stenosis, always diastolic. You got it? If you remember that, you will nail your murmur questions on the exam. But you know what else? You'll nail them in practice as well. So somebody asked me, hey, Amelie, how long did it take you to come up with that? Well, to be honest with you, my brother and I sat down one Thanksgiving with a bottle of wine, and in 30 minutes we had it. And my brother's an attorney, so he's not an NP. So anyway, I think you'll learn it. So listen, I'm not going to go through every one of these with you, but let me show you what I expect you to be able to do at this point. You should look at a murmur like aortic stenosis and be able to tell me right now, is it systolic or diastolic? Mr. Peyton Manning as MVP, it's got to be systolic. Where do you hear the noise the loudest? Well, it's an aortic murmur. Where do you hear it loudest? Aortic listening point. The third thing, and remember these come from Amelie's 3 easy steps to murmur identification. What else is going on with the murmur? That's going to be the hardest one for you to learn until you have a patient who's got that problem. So with aortic stenosis, they have angina. These are the people who always come in with chest pain. They'll tell you, oh, I'm having chest pain. Oh, yeah, Ms. Boudreaux had aortic stenosis. She used to have all those syncopal episodes in the bathroom until she finally got a new valve. That's how you'll remember what the associated findings are, all right? So spend a little time and make this one of your goals for 2015 because honestly, it's not nearly as hard as somebody led you to believe, all right? So take a look at these. I'm going to just go through them And I'm going to make a stop on mitral regurg and let you put a star by it. It's very, very common, and I think you'll see it again. Certainly in practice, you hear this all the time. And the last one I want to put a star by, or you to put a star by, is mitral valve prolapse. It is the most common adult murmur. Up to 10% of the adult population probably has this. It almost always is benign, but on your exam, it is absolutely the easiest murmur to identify, and here's why. It is the only murmur that clicks. It's a mid to late systolic click, all right? So you'll hear a mid to late systolic click when you put the stethoscope on a patient's chest, and boom, you'll have it, all right? Who gets MVP? Mostly women. When are they usually diagnosed? Childbearing age. What are the most common symptoms? Chest pain and palpitations, especially if they do what? Drink too much Starbucks. You got it? Anything that increases their heart rate will precipitate their symptoms. All right, let's take a big deep breath. Let's see where you are with your cardiac knowledge. Excuse me. Which antihypertensive med is most commonly associated with erectile dysfunction? Like this one is at the top of the list. What is it? Before the study came out, I would have said number 2, number 3, or number 4. A very large, well-done study that came out of the VA showed that the number 1 drug associated with erectile dysfunction is hydrochlorothiazide, which doesn't mean you shouldn't use it. It means you need to ask the questions when you prescribe it. So number 1 is your best answer. Angioedema is frequently associated with which medication? The ACE inhibitor? Lisinopril? Yep. Let me ask you, which population is at highest risk for development of angioedema secondary to an ACE? African Americans, exactly. So make sure that's part of your teaching plan when you prescribe that if you do. What disease might predispose a patient to an electrolyte abnormality if an ACE or an ARB is prescribed? What disease would predispose you to an electrolyte abnormality if you give an ACE or an ARB? Well, what do the ACEs and ARBs do? They cause you to hold on to potassium, right? I don't think hypertension necessarily does it. Patient with diabetes, I don't necessarily think does it. But I want you to think about number 3. If you've got heart failure and we put an ACE or an ARB in you, it certainly increases your risk of hyperkalemia, although it probably will improve your heart failure, all right? So circle number 3. What about renal dysfunction? If you can't get rid of potassium and I give you an ACE or an ARB, you're going to end up hyperkalemic, right? So what I would tell you is that when you prescribe an ACE or an ARB to any patient with heart failure or renal dysfunction, you better have both eyes on this patient very carefully, because you always have the potential to push him over the edge into a state of hyperkalemia. That's not a good place to be. Everybody got it? All right, let's look at another one. Which patient might be most likely to exhibit a physiologic murmur? Okay, wait, is that good or bad? Here's what you should remember. Diastolic murmurs are always abnormal. Systolic murmurs can be normal or not. A physiologic murmur, what is that? Mr. Peyton Manning, PM. So it's a systolic murmur. Who's most likely to have that? A 16-year-old. Physiologic murmurs occur because that little heart is growing and stretching in this turbulent blood flow. You got it? Listen, think about this. When you were born, your heart was the size of a walnut. Right now, as an adult, your heart is the size of a fist. So to get from this size to this size, a lot of growing and stretching has to take place. When there's growing and stretching in a heart, there is turbulent blood flow. And when there's turbulent blood flow, you hear murmurs. That's what a physiologic murmur is. Who's most likely to have a growing heart? A 16-year-old, circle number 1. What common symptoms might be associated with MVP, mitral valve prolapse? Well, I gave them to you. What did I tell you the lady or the female is most likely to have? Palpitations because of premature atrial contractions, or PACs. What about atrial fib? Do they have atrial fib? No. You know people with mitral valve prolapse, they're not on Coumadin. Look at number 3, chest pain. Do they have that? Yeah, they do. So circle number 3. Do they have shortness of breath? They don't have shortness of breath, right? But they have chest pain and they have palpitations, number 1 and number 3. All right. I'm going to make a bet with you right now. You betting mood? I'm going to bet everybody in here $1. I'm going to bet you $1 that you know more about murmurs than you think you do. All right, what you said? You get the $1. I don't know. I'm going to win the $1. I'm going to just tell you right now. Here's your first murmur patient. You ready? A 50-year-old plumber has a systolic murmur that is best heard at the apex of the heart. I want to know the name of the murmur. So listen, here's what you're going to do. It's a systolic murmur. What's your acronym? Mr. Peyton Manning is MVP. Where do you hear it the loudest? The apex. What listening point is that? The mitral listening point. So I am looking for a systolic mitral murmur. Could it be mitral stenosis? No. That's the MS of arms, and that one was diastolic. It cannot be number 1. Look at number 2. Number 2 says aortic stenosis. It cannot be aortic stenosis because it's heard loudest where it originates, in the apex. That's a mitral listening point. It cannot be an atrial murmur. Sorry, an aortic murmur. Look at number 3. Mitral regurg is mitral. Mitral regurg is the MR. Mr. Peyton Manning is MVP. It's systolic. I like number 3. It cannot be number 4 because that's aortic. Do you agree that it's number 3? Yes. Let's look at another one. A secretary has symptomatic aortic regurg. So now they're telling you what the murmur is. It's aortic regurg. Systolic or diastolic? Diastolic is the AR of arms. Diastolic murmurs are always abnormal, right? They're always bad. Look at the question. What would you expect in listening to the murmur? Well, look at number 1. A late diastolic click. Well, the only one that clicks is which one? MVP. So not number 1. Number 2 says diastolic sounds good, because this is a diastolic murmur, heard loudest near the second intercostal space, right sternal border. What listening point is that? Aortic. So this is aortic and diastolic. I like number 2. Let's see what number 3 says. Diastolic sounds heard in the mid-sternal area. Well, honey, there's nothing right here, right? All right, so it's not that one. Look at number 4, intermittent diastolic. Diastolic murmurs come every time the heart beats. What is your best answer? Go back up to number 2. You see how you can pick your way through them? Let's look at another one. A 48-year-old female who is a cook has been diagnosed with mitral stenosis. Is that good or bad? Bad. MS of arms. I want to know what you would expect in listening to her murmur. All right, so it's mitral stenosis. Number 1 says a late systolic is not systolic. What is it? Diastolic. Look at number 2. Radiation of soft diastolic sounds into the neck and carotid arteries. You got to be kidding me. Listen, the mitral listening point is right here. There is no way you can hear noise in the neck. That's a lie, not that one. Look at number 3. Diastolic sounds heard loudest near the apex. I like it. Look at number 4. Soft diastolic sounds in the left mid-clavicular area. What's your best answer? Number 3, exactly. Here's your next patient. A retired banker walks 30 minutes daily. He complains of mild chest pain and presents with a soft murmur near the second intercostal space to the right of the sternum. What listening point is that? Aortic listening point. There are audible sounds over the carotid arteries in conjunction with the murmur. What are they telling you about when this occurs? Systole. So you've got a systolic aortic murmur. What is it? Look at number 1. Aortic regurg. It's aortic, all right, but is that systolic? No, it's diastolic. It's the AR of arms. Number 2 is carotid artery disease. No, it's a murmur. Number 3 says mitral stenosis. It cannot be that one because this is an aortic murmur. Look at number 4. Aortic stenosis, Mr. Peyton Manning as MVP. It's got to be number 4. So do you see how you can pick your way through these murmurs? Do you realize that they're not nearly as hard as somebody led you to believe? All right, take a look. A 56-year-old male complains of pain in his lower legs when he walks. He gets complete relief when he stops and he rests. What historical findings might be present? Well, first of all, what does this man have? Intermittent claudication. It's secondary to what disease? Peripheral artery disease, right? What I am asking you is, what are the most likely characteristics we see in someone with peripheral artery disease? My money is on the fact that he's diabetic. I would never be surprised if he was diabetic. I would never be surprised if he smoked. He has dyslipidemia. I would never be surprised if he had dyslipidemia because that's what's contributed to the buildup in the arteries. Look at number 4. He takes an aspirin daily. Does that contribute to these symptoms? No. Circle number 1, number 2, and number 3, and those represent 3 big risk factors for peripheral artery disease.